Welcome to Raaonline. Today, we have a very interesting and very important topic, not only for your exams, but also for your clinical practice, the hepatorenal syndrome. So, the basics of hepatorenal syndrome is, in a patient with a liver failure, if the kidney also fails, it is called as hepatorenal syndrome, right? Every one of you will know that. The treatment is going to be albumin and terlipressin, and it's going to be a deadly disease. Of course, there are type 1 and type 2. Type 1 is very deadly, where the patient might die in 10 weeks' time, less than 10 weeks' time. And liver transplantation is the only ultimate treatment for this. So, this is the basics what we know about hepatorenal syndrome. Okay. So, let us slow things down. If a patient with cirrhotic liver failure comes to you with a worsening creatinine, which is very fast in worsening, there's a chance you can claim that patient as HRS type 1, and you're going to prognosticate and tell them that the patient may die in 10 weeks, right? My question to you is, how sure are you that this particular kidney disease is because of the liver? How sure are you that this is exactly hepatorenal syndrome? What if it's just a benign prostatic hyperplasia and because of that there is a renal failure? What if it's a pyelonephritis and there is a renal failure? What if it's a pre-renal failure because of the diuretics, dehydration, or any other cause? A cirrhotic liver patient can have other causes of kidney failure as well, right? So, a benign prostatic hyperplasia or a pyelonephritis need not die in 10 weeks' time. So, you need to understand what is hepatorenal syndrome on the first place. What is the mechanism behind it and what type of treatment are you going to give? Moreover, the timing of that particular treatment strategy is very important. When to do paracentesis, when to give albumin during paracentesis, why are we giving terlipressin? So, at what stage you will increase the dosage or what stage will you consider for liver transplant? Everything is important. So, blindly, if a patient with cirrhotic liver disease comes to you with the elevated creatinine, do not claim that patient to be hepatorenal syndrome. That's the first place what I want to tell you, right? There are n number of causes where the hepatic patient, a cirrhotic patient can have a renal disease because of other causes as well. So, the first point which I'm going to tell you is hepatorenal syndrome is a diagnosis of exclusion. You need to exclude all the other causes of that kidney failure. Only then you need to comment about hepatorenal syndrome, right? Because this is going to be extremely deadly disease. Not only this disease, any disease in your practice, if it's going to be a deadly disease where the treatment is of very, very low effect, then you need to double confirm the diagnosis, discuss about all the other differential diagnosis. Only then you need to come to that particular deadly disease diagnosis. Okay. So, hepatorenal syndrome for you. HRS is a serious complication of end-stage cirrhosis and portal hypertension. Okay. So, what exactly happens is that the liver becomes tight. Okay. In emergency and intensivist language, we call that particular organ as tight. For the brain, we call this a tight brain. For ARDS, we call it as a tight lung. Similarly, for intensivist and emergency physician language, we call this as a tight liver basically. So, because of the pressure inside that liver, there is portal hypertension. Because of portal hypertension, in the gut, there will be splanchnic vasodilatation. Splanchnic vasodilatation. There will be increased splanchnic vasodilatation. So, because of increased splanchnic vasodilatation, there is a distributive type of shock. Okay, the blood gets pooled in the splanchnic circulation. So, the effective central volume is less. So, all the blood gets pooled in the splanchnic circulation. So, the effective central volume is very, very, very less. So, because of that, there is a reduced blood supply to the kidneys. Thus, the GFR goes down. Okay, simple. So, because of the cirrhotic liver, because of the portal hypertension, there is increased splanchnic blood flow and vasodilatation at that point, the splanchnic point. So, there is effective central volume decreased. So, because of the effective central volume going down, there is reduced blood supply to the kidney, basically like a pre-renal failure. Okay. So, now understand there is auto-regulation in the kidney itself. Okay. When you take the kidneys, okay, there is auto-regulation. Okay. Think this is efferent and this is afferent. Okay. Whenever the blood supply to the particular kidney is compromised, the efferent vessels dilate, the efferent arterioles dilate, and they try to give more blood to the kidneys. But at this point of time, if you give a NSAID and if you take off this reflex, then this efferent reflex is also lost and the kidney can get shut down immediately. Not only by your NSAIDs, even with your systemic infection, systemic inflammation, this can happen. Okay, so this is very, very important. So understand this very clearly. Because of cirrhosis of the liver, portal hypertension develops. Because of that, there will be splanchnic vasodilatation. Because of it, most of the blood gets pooled in the splanchnic circulation. So central blood volume is decreased. So blood supply to the kidneys are also compromised. So marked reduction in the GFR and absence of evidence of intrinsic kidney disease should be documented. Okay. So on a first place, whenever you see a patient with liver disease, okay, along with kidney failure, the first thing you need to notice, the kidneys are anatomically normal. Okay, you need to make sure the kidneys are anatomically normal. Okay, you need to document it is only because of the liver that the kidney is failing. There is no intrinsic kidney disease at all. Okay, then only it's called as HRS, right? It's only a functional kidney disease, not an anatomical kidney disease. So you have to document it is because of the liver and nothing else. Okay, so what all will you do? You do an ultrasound to look for the size of the kidneys, to look for any post-renal obstruction in terms of pyelonephritis, in terms of renal disease, in terms of prostatomegaly, instead of any other tumor in the bladder, all these things. And you also need to check how is the membranes of the kidney. How will you do that? You check the urine routine examination, check there should not be any hematuria, there should not be any proteinuria. Okay, so all these things tells you that there is no intrinsic kidney disease. Got it? So whenever you see a patient with cirrhosis of the liver coming with a renal failure, you need to document anatomically the kidney is normal in terms of ultrasound abdomen, in terms of urine routine examination. Prove that there is no intrinsic kidney disease. There is no post-renal obstruction. Okay. Sometimes you need to give adequate fluids to check whether it's because of pre-renal failure, because of dehydration. Okay. So all the other parameters has to be handled. Only then you need to comment about HRS. Okay, so HRS keywords in cirrhosis, marked reduction in the GFR, and absence of evidence of intrinsic kidney disease, meaning no hematuria, no proteinuria, and there's no abnormality in the kidney in ultrasound abdomen. So, updated definitions. So, as the definition of acute kidney injury evolved over years, the definition of HRS also evolved. Okay, so in 1996, they had the serum creatinine criteria, urine sodium criteria, urine volume criteria, urine sediment, and other miscellaneous criteria as well. Okay. So in short, serum creatinine should be more than 1.5 grams per deciliter, or 24-hour creatinine clearance should be less than 40 ml per minute. And of course, they check the urine sodium. Okay, the urine sodium has to be very, very proper, meaning the kidney has to conserve sodium. Urine sodium will be less than 10 milligrams per liter. Okay. Of course, the GFR has to be reduced to call it as a kidney disease. So less than 500 ml per day has to be there. Got it? And check the urine routine, absence of any structural kidney damage defined by proteinuria less than 500 and RBC less than 50. Other miscellaneous criteria, cirrhosis or acute liver disease with portal hypertension, absence of shock or ongoing infection or any other nephrotoxic drugs. Okay, all these things should be ruled out. This was claimed in 1996. Then in 2007, there is another group which come up with the updated definition. That is serum creatinine more than 1.5 milligram per deciliter or doubling of serum creatinine to 2.5 milligram per deciliter within 2 weeks. Here, they took off this urine sodium criteria, okay, because most of these patients are treated with Lasix. Most of these patients are treated with Lasix because of the tense ascites, because of other breathing difficulty, because of some additional cardiac components. These patients are usually treated with Lasix because of poor urine output. By some day or the other, these patients are treated with Lasix. For that reason, urine sodium can be messed up. So they took off this urine sodium at all from the definition. Okay, and even urine volume, the patient will not wait for long for a urine volume to be less than 500 ml because collection itself was very difficult, right? To measure from the home is going to be very difficult. So they took off this urine volume as well. And when the patient is on Lasix, that cannot be taken as patient's normal urine volume or baseline urine volume. So because of Lasix, these two values are messed up, right? So they were taken out in 2007. The other definitions are almost the same, meaning the urine sediment criteria and miscellaneous criteria. In 2015, the definition of AKA itself changed. Definition of AKA itself changed because you need not wait for 2 weeks. Okay. Is there any way you can identify this in 2 days' time? That was the question. So in 2015, they came up with another criteria, that is increase in serum creatinine by more than 0.3 milligram per deciliter within 2 days, within 48 hours. Or increase in serum creatinine of more than 1.5 times the baseline. Okay. So what is meant by baseline? Within 7 days, you should have a serum creatinine within 7 days. For example, the patient comes to you on day 7. Okay. For example, 7th of March, the patient comes to you at 7th of March and with a creatinine value of so and so. You should have a baseline creatinine which is done within 7 days before. Okay. Which is very less likely in a country like India. Right. So they just made this definition a little more flexible, stating if you don't have a baseline creatinine within 7 days, you can use the baseline creatinine which is taken over a period of 3 months. So within the past 3 months, there should be some baseline creatinine. With that, you can compare and you can use this criteria. Okay. So increase in serum creatinine by more than 0.3 milligram per deciliter within 48 hours, or increase in serum creatinine of more than 1.5 times from the baseline. The meaning of baseline is usually within 7 days, you should have a baseline creatinine. 7 days before, within 7 days before, you should have a baseline creatinine. If you don't have within 7 days, then you can use the creatinine value taken around 3 months previously. Okay. And urine volume less than 0.5 ml per kg per hour for 6 hours. And of course, the other criteria remains the same. Okay. So in 2019, they changed the name as well, the definition as well. Okay. They named it as HRS type 1, which is called as HRS AKI, acute kidney injury. Okay. So understand this, hepatorenal syndrome is of 2 types, HRS 1, HRS 2. HRS 1 is called as HRS AKI. HRS 1 is called as HRS AKI. HRS 2 has again 2 more divisions. Okay. What is HRS 2? HRS 2 is nothing but, which is not in HRS 1, is HRS 2. Otherwise called as not AKI or non-AKI, which is called as NAKI, N-A-K-I. AKI comes in HRS type 1, non-AKI comes in HRS type 2. Okay. That NAKI, the NAKI, the non-AKI, it's of 2 types. We'll see the 2 types in the next few slides. Okay. So in 2019, this HRS type 1 is named as HRS AKI, meaning increase in serum creatinine more than 0.3 within 48 hours or increase in more than 1.5 times the baseline. And they have considered FENA to less than 0.2% and other criteria is almost the same. But additionally, they have come up with one more thing, which is NGAL. Okay. NGAL tells you about intrinsic kidney disease. Okay. So the urinary NGAL is less than the baseline, that is 220 micrograms per liter. So that tells you that the particular kidney's structure is normal. There is no intrinsic kidney disease. Okay. So this is the latest definition. 2019 is going to be the latest definition. So when you see a patient with cirrhotic liver, decompensated cirrhotic liver, comes to you with a renal insult, then you need to check whether the serum creatinine increased by 0.3 milligram per deciliter within 48 hours or more than 1.5 times the baseline. The baseline meaning within 7 days. If you don't have value within 7 days, you can use value up to 3 months before. FENA and urine criteria, and of course, absence of intrinsic kidney disease as said by the urine routine and ultrasound abdomen. Okay, there should not be ongoing shock, there should not be ongoing bacterial infection, and no nephrotoxic drugs. So, functional kidney injury that does not meet the criteria of HRS AKI is termed as HRS not AKI. Okay, I told you HRS type 1 and type 2. Type 1 is called as AKI. HRS type 1 is called as AKI, acute kidney injury. Okay, we have a definition for it. What is the definition? Just now we saw the definition, right? 0.3 increase in serum creatinine, 0.3 milligram per deciliter in 48 hours or more than 1.5 times the baseline, right? That is HRS AKI. If that criteria is not met, then those patients come under HRS non-AKI. The non-AKI is called as NAKI, N-A-K-I. This HRS non-AKI is of two types. Okay, two types are HRS acute kidney disease. This is injury, this is disease. Okay, the second type is CKD, AKD and CKD. Okay, clear? So HRS is divided into type 1 and type 2. Type 1 is called as AKI, the definition we know it, that is 0.3 milligram per deciliter should increase within 48 hours or more than 1.5 times the baseline. Type 2 is divided into two things. What is type 2? Which is not coming in this criteria is called as type 2. It's called NAKI, N-A-K-I. Type 2 is of two types, one AKD and CKD. Okay, how to differentiate AKD and CKD? If the eGFR is less than 60 ml per minute per 1.73 meter square, in less than 3 months, it's AKD. More than 3 months, it's CKD. That's all it is. Simple. Okay. So this definition is also very important, dear friends. So again, coming back to step number 1, I'm repeating this again and again because understand, it's very easy for you to coin a patient's hepatorenal syndrome. But the moment you coin the patient's hepatorenal syndrome, it means that patient is going to die in less than 10 weeks, especially the type 1 variety. So you need to understand this is a diagnosis of exclusion. Check whether the kidneys are intrinsically damaged. Check whether there's an infection or shock or a nephrotic ducts going on. All these has to be ruled out. Only then you can classify the patient as HRS. Even if you classify the patient as HRS, give him a chance to live, right? So you need to classify it as HRS type 1 or type 2. Type 1 is extremely fatal. Okay, that's the reason you are going to classify these patients. So type 1 is called as AKI. Okay, you know the definition, right? Whichever is not fitting in the definition comes to type 2. Type 2 is divided into AKD and CKD based upon the duration. Okay, less than 3 months AKD, more than 3 months CKD. Okay, less than 3 months AKD, more than 3 months CKD. Okay, if the eGFR is less than 60 ml. So now coming to the pathophysiology. Okay, so it's a tight liver, cirrhosis of liver, has a portal hypertension. Because of that, splanchnic vasodilatation happens. When there is vasodilatation happens in splanchnic circulation, effective arterial central blood volume is decreased. So because of that, there is renal vasoconstriction, right, to conserve more fluids. Okay, so this is one line about the pathophysiology. Now let's go very deep into the pathophysiology. Okay, start again. So this is cirrhosis of liver, basically a tight liver, and portal hypertension develops. And this increases nitric oxide. Okay, to be very specific, it not only increases nitric oxide, it actually disturbs the nitric oxide balance. In some areas, nitric oxide is increased. In some areas, nitric oxide is decreased. Okay, so it just disturbs the nitric oxide balance. Okay, it puts out prostacyclins, puts out carbon monoxide, puts off endocannabinoids. Okay, because of portal hypertension itself. All these things actually do splanchnic arterial vasodilatation, right? What do you mean by splanchnic arterial vasodilatation? This is basically the gut. So inside the gut, what is there inside the gut? Inside the gut, there are trillions of bacteria. So when there is splanchnic vasodilatation, this possibly GNB bacteria, like E. coli mostly, right? So this GNB bacteria and other anaerobes, they get translocated inside the blood system. So the patient develops infection. Patient develops bacterial translocation because of that infection. But understand certain things, dear friends. Even without bacterial translocation, even without infection, SIRS sets in. Systemic inflammatory response syndrome sets in even without infection. Of course, the patient does have an infection in future, but even before that, because there is splanchnic vasodilation, the body gets alerted and there is systemic inflammatory response syndrome. Okay, so pro-inflammatory cytokines are increased, vasodilation is increased, and bacterial translocation happens. Okay, so when the bacterial translocation happens, bacteria enters into the blood circle. So once bacteria enters into the blood, PAMPS and DAMPS increase. What's that PAMPS? Pathogen associated molecules are called PAMPS. Damage associated molecule. Your cells are getting damaged. The patient cells are getting damaged. Damage associated molecular proteins are called DAMPS. So the PAMPS and DAMPS will worsen the condition. So let's start again. So there's a tight liver because of the portal hypertension. Because of that, the nitric oxide is messed up, prostacyclins, CO and sorbent monoxide and endocannabinoids are increased, splanchnic arterial dilatation. Because of the dilatation itself, cirrhosis sets in. Once it is dilated, the bacterial translocation happens. Once it happens, pathogen associated molecules and damage associated molecules are increased. Okay, so effective blood volume is decreased because of the infection, because of the cirrhosis. There is cardiomyopathy as well. Okay, look at the situation, dear friends. The heart is not able to pump because of cardiomyopathy. The heart is not able to pump because of cardiomyopathy. There's cardiogenic shock there. And because of splanchnic vasodilatation, there is distributive shock there. Because you already treated the patient with classics, there is hypovolemic shock there. Because there is translocation of the gut bacteria, there is septic shock. Okay, so this is one area where you have septic shock, cardiogenic shock, distributive shock without a infective reason. It's not infection related distributive shock. This distribution is because of nitric oxide, prostacyclins, carbon monoxide, endocannabinoids. And because of your Lasix and stuff, this patient can have hypovolemic shock. Okay, so all these things starts to converge and affect the kidneys. All these things will not allow effective blood flow to the kidneys. Okay, so what happens is whenever there is hypovolemia, whenever there is decrease in central blood volume, your RAAS and SNS gets activated. Your RAAS and SNS gets activated. It tells the kidney that we don't have adequate blood in the body, so you conserve the urine, you conserve the blood flow, right? So RAAS and SNS, what it does is it goes to the kidneys, does vasoconstriction to the kidneys, further worsening the situation. Okay, so only thing which is going to save the kidneys intrinsic autoregulatory mechanism at the efferent arteriole. So now you are giving NSAID, that is also lost. Okay, whether you are giving NSAID or not, eventually, even that efferent arterioles autoregulatory mechanism has a capacity, has a limited capacity. When that capacity is overwhelmed, renal insult happens. Okay, so this is the complete pathophysiology of hepatorenal syndrome. Okay, so understand, till this time I am speaking everything which is before the kidneys. I never said you anything about the kidney or after the kidney. So it's up to you to prove that the kidney anatomically and by membranes and function, the kidney is normal, and after the kidney there is no post-renal issues. Okay, the kidney should be normal, the ureters and the post-renal thing has to be normal. Okay, you need to document possibly there is a cirrhosis, there is a portal hypertension, there is splanchnic vasodilatation, there is an infection, there is cirrhotic cardiomyopathy, possibly there is decreased effective arterial volume, and all the systems are active in place. Now, as I was saying, the kidneys try to compensate by vasodilatory effects of renal prostaglandins, the E2 and E1 on the afferent renal arterioles. So, when there is a damage to the liver, there is a cirrhosis of the liver, and because of the splanchnic vasodilatation, there will be effective decrease in the central blood volume. So, ultimately, there will be decreased blood supply to the kidneys. Okay, to the kidneys. So, there will be afferent and there will be efferent arterioles. So, there will be afferent arteriole dilatation. Okay, because of autoregulatory mechanism of the kidney, whenever the renal system is not receiving adequate blood, there will be decreased blood supply to the kidneys. So, the autoregulatory mechanism kicks in and there will be afferent arteriole dilatation. Okay, so when you give NSAID, what happens? This reflex is lost. So, ultimately the kidney will suffer. So, whether you give NSAID or not, okay, ultimately this particular autoregulatory mechanism has its own limitations, right? So, when the particular HRS is worsening beyond this autoregulatory capacity, the kidney goes for shutdown. Okay, this maintains the glomerular pressure despite reduced renal blood flow. Okay, progression of liver disease and the use of NSAIDs that inhibit this prostaglandin synthesis disrupts this balance and causes AKI. So now we know the liver has done its part. Now we need to understand the cardiac system can also be affected, especially the diastolic dysfunction, systolic dysfunction, and cardiac output basically. So in a study of 66 patients who had cirrhosis with ascites and normal serum creatinine levels, baseline MAP and cardiac output was significantly better in patients who did not have HRS, and it was worse, okay, diastolic dysfunction, system dysfunction and cardiac output was less in patients who developed a HRS. So there is direct correlation with the dysfunction and decrease in cardiac output and HRS. Moreover, plasma renin activity and cardiac output were independent predictors of HRS. Okay, so why plasma renin activity? This is the RAAS system, RAAS. Okay, this is a RAAS system, right? So decrease in cardiac output and increase in RAAS system both were independent predictors of HRS. So complications occurred if significant reduction in the MAP, basically the blood pressure, mean arterial pressure, cardiac output, or wedged pulmonary pressure, right? If at all the arterial system is not able to maintain the blood supply, then all these things is going to get worsened out. Or if the mechanisms like RAAS, that is plasma renin activity, SNS, so sympathetic nervous system, the norepinephrine activity, or hepatic venous gradient is on the higher side, it also has a very worse prognosis. If these things are low or if these things are high, it has a very worse prognosis. In another study, patients with SBP at diagnosis and after resolution of infection, those who developed a HRS had low cardiac output, okay, indicating that there is direct connection between the low cardiac output and HRS. In patients who did not develop HRS, the cardiac output was much better in that particular segment of patients. So, ultimately, whenever you speak about the liver, whether you speak about the portal hypertension or the splanchnic vasodilatation or the bacterial translocation or the particular RAAS system, ultimately it culminates towards vasoconstriction of the renal circulation, right? Ultimately, lower blood supply to the kidneys. So, why there is low blood supply to the kidneys? Because of two major vasoconstrictor systems. What are the system? RAAS and SNS. You need to know about what is RAAS and what is SNS. RAAS is the Renin-Angiotensin-Aldosterone system. Okay. In several studies of patients with cirrhosis, the activity of RAAS, meaning the plasma renin activity, increases when the liver goes from compensated to decompensated cirrhosis. Okay. Of course, beyond the decompensated cirrhosis, when the patient goes to HRS, that is when the RAAS activity, the plasma renin activity is at its peak. Okay. So, the RAAS activity, when it increases, the kidney function worsens, HRS worsens. So, it's inversely related to the kidney function. Especially patients with infection with an HRS, there's a higher RAAS activity. Okay. So, HRS, of course, if there's a precipitating event, there's going to be higher RAAS. If there's a higher RAAS, there's lower probability of HRS reversal. Okay. So, what is this HRS type 1 and type 2 difference? We have said you about the criteria, but the pathophysiological point of view, both are one and the same. HRS1 and HRS2 are one and the same, except there's a precipitative event to that particular patient which has worsened the clinical situation and pushes this patient towards HRS type 1. Okay. So, HRS type 1 and type 2 are not two different things. They are the same, except that in HRS type 1, there is some event which has puts the patient into worsening criteria. Okay. Possibly that's going to be an infection. Okay. So, when the patient has infection with HRS, there will be a higher RAAS system. When there's a higher RAAS system, there's low probability of HRS reversal. Now, coming to the SNS, the sympathetic nervous system. Plasma levels of norepinephrine increased in HRS than in those with ascites and intact kidney function. Okay. Of course, it also inversely correlated with the GFR. Of course, there are other vasoconstrictors like endothelin, cystinyl leukotrienes and prostaglandins. Okay. So, in pathophysiology, what all did we see? We saw the mechanism, right? We saw that how the diastolic dysfunction, systolic dysfunction, low cardiac output can worsen the situation. Okay. So, this worsening diastolic, systolic or low cardiac output can be because of the infection, can be because of the CIRS, or it can be an intrinsic cardiac disease itself. Okay. It can be intrinsic cardiac disease, or because of various other etiology, like even hypovolemia can cause low cardiac output, right? Even hypovolemia can cause low cardiac output. And of course, we saw about the RAAS system, the renin-angiotensin system. We saw there are a lot of studies. It says increase in RAAS can worsen vasoconstriction in the kidneys. Similarly, SNS, increase in norepinephrine, noradrenaline can worsen the system. Now, we are going to see about nitric oxide dysfunction and DAMS and PAMPS. Nitric oxide dysfunction. Okay, so I'm using the word dysfunction. I'm not saying it is less or more. Okay, because both excessive or insufficient nitric oxide production occurs. Both occurs in this particular segment. Okay. Excess nitric oxide production results in spank-link vasodilatation. Okay. So, when it dilates, effective arterial blood volume decreases, RAAS increases, SNS increases, renal vasoconstriction occurs. Okay. If in certain areas there is less nitric oxide, where at the renal blood flow. Okay. In the spank-link circulation, nitric oxide is overproduced, so there is vasodilatation. At the kidneys, the nitric oxide is produced very less, so there is vasoconstriction. Okay. So, low nitric oxide due to the increased production of dimethyl arginines. This is called as SDMA, which is symmetric SDMA, asymmetric ADMA. Okay. Because of increased production of this dimethyl arginines, nitric oxide is not produced. Okay. The ADMA, SDMA levels are increased in advanced liver disease, and therefore NO synthesis from NO synthase is inhibited and the renal blood flow is compromised. These things acts at the level of kidneys. Hence, SDMA and ADMA itself can be taken as an independent predictor of GFR in cirrhotic patients. So, systemic inflammation. So, understand this concept. There are other causes of systemic inflammation in any patient, right? For example, you will call a pancreatitis as a non-infective sepsis. You will call burns as a non-infective sepsis, right? Similarly, there are other factors, there are other conditions where the patient can have a CIRS without an infection. Similarly, HRS itself can put forth many systemic inflammatory pro-cytokines. Okay, this itself can trigger a CIRS criteria. Of course, the patient can have an infection, but this CIRS is independent of that infection. Okay, so independent of the presence of actual infection, plasma levels of pro-inflammatory cytokines IL-6, tumor necrosis factor alpha, and urinary levels of monocyte, chemoattractant, protein 1 are increased in HRS AKI. Okay, than in decompensated cirrhosis without AKI, or in AKI because of any other disease. Okay, so there should be a kidney disease, and that kidney disease should be because of the liver. Okay, only then these things are very much increased. That's what this says. These are increased in HRS AKI, okay, than in patients without AKI, okay, and those in AKI because of any other cause. Okay, very, very important. So, why should there be a systemic inflammation? There is altered intestinal permeability, translocation of gut bacteria to the mesenteric lymph nodes. Okay, this actually increases the vasodilatory factors such as NO. When the nitric oxide increases, the spank-link circulation increases. So, when the spank-link circulation increases, there is going to be pooling of blood in the spank-link circulation. So, decreased effective arterial blood volume. Pro-inflammatory cytokines increases, PAMPS and DAMs increases, pathogen-associated molecular patterns and damage-associated molecular patterns. So, these induce inflammatory responses through activation of pattern recognition receptors. That's called toll-like receptors, TLRs. So, what is this PAMPS and DAMs? PAMPS are nothing but products of bacteria. That's a lipopolysaccharide, LPS, we say LPS, right? Flagellin, nigericin, sort of, basically from the bacteria. DAMs are intracellular components released from injured hepatocytes. That's from the patient, like high mobility group protein 1b, heat shock proteins, hyaluronic acid, all these things. These are DAMs. Okay. These promote inflammation and release of pro-inflammatory cytokines, and also these PAMPs and DAMs have direct effect on the kidneys, thus worsening the kidney disease. So, slowly I am trying to tell you that initially we started telling that there should not be any intrinsic kidney disease. Right? That's what we started telling. That's how we started explaining HRS. But over a period of years, we understood systemic inflammatory response syndrome is also present. When there is systemic inflammatory response syndrome, almost every organ system in the body is going to get affected, including the heart, including the lung, including the kidneys. So, there can be some amount of intrinsic kidney disease as well. Okay? Understand this point. There can be some amount of intrinsic kidney disease as well because of CIRS. But to start with, exclude everything, only then you can claim the patient to be HRS. Okay, this CIRS affecting the kidneys directly, causing intrinsic kidney disease can be around 5 to 10%. Okay, but at large, you need to make sure it is not a direct kidney disease because of pyelonephritis or stone disease or hypovolemia or an obstructive patterns. Okay, so in a study, patients with kidney dysfunction cirrhosis, patients showed increased renal expression and urinary excretion of this toll-like receptors. Okay, so hence this TLR4 is a mediator of kidney injury. Okay, moreover, we said you that the gut translocation happens and PAMPS and DAMPS develop, which increases the TLR, right? So, when you sterilize the gut, when you decontaminate the gut in rodent models, this renal TLR also decreased. So, when renal TLR decreased, the kidney was also preserved, okay? So, you sterilize the gut, TLR is decreasing, kidneys are being saved. So, this suggests that the exposure to PAMPS from the gut bacterial translocation increases TLR4 expression in the kidneys.